Thank you all for logging on to today's webinar, where we will begin in about 2 minutes. Thank you all for joining us today. I would like to welcome you all to IRETA's webinar, Improving Clinical Quality in Methadone Treatment, Results of a 2-Year Pilot. My name is Jessica Samuel, and I'm the project coordinator at IRETA. I'll be moderating the webinar today. At this time, I would like to go over some housekeeping items for today's webinar. We would like to encourage you all to participate in the webinar via 3 methods. First, if you have questions for Dr. Luongo or Dr. Lindsay, or are experiencing any technical issues, please use either the chat box or the questions pane to communicate your questions. At the conclusion of the main presentation, Dr. Luongo and Dr. Lindsay will stop and ask for questions. At that time, I will read aloud any questions that have been submitted. Again, you can submit questions via the comment or questions box. Throughout the webinar, all participants will be on mute. Following the webinar, you will receive an email with a link to the evaluation, and the webinar has been approved for 1.5 PCB and/or NADAC credits. You can also request a general certificate of attendance. Certificates may take up to 48 hours to appear in your profile, so we ask for your patience. I'll go over all of this again at the conclusion of the webinar. At this time, we would like to go through 4 poll questions. We'd like to get a picture of the demographics of those in attendance and their possible experience with providing methadone maintenance. There are no wrong answers. These questions have now appeared on your screen as an interactive poll. Please take a minute to select the best answer as it applies to you. Okay, I'm now going to close the poll, and then in about 20 seconds, everybody will be able to see the answers on the screen. As far as current professional roles, it looks like we do have some program or unit managers, some counselors, and some nurses on. It looks like the main field of representation today is addiction. We have about an even split of people who are working in a setting with methadone. And for the 4th question, it's just about a 50-50 split also. So thank you guys for participating. I would now like to introduce Dr. Peter Luongo and Dr. Dawn Lindsay. Peter Luongo is the Executive Director of the Institute for Research, Education, and Training in Addictions, the former single state authority of Maryland. He has over 30 years of experience in the behavioral health field as a social worker and administrator. Dr. Luongo has served as a faculty associate at Johns Hopkins University, where he received the Johns Hopkins University Excellence in Teaching Award in 1996. In 2008, he received the Maryland Social Worker of the Year Award from the National Association of Social Workers, and in 2012, he was selected as one of the 50 Heroes for Justice by the University of Maryland School of Social Work. In 2015, Dr. Luongo was elected as a Class A trustee of the General Services Board of Alcoholics Anonymous. Dr. Dawn Lindsay is the Director of Research and Evaluation at IRETA. Prior to joining IRETA, she served on the faculty at the University of Pittsburgh studying the development of adolescent substance use disorders. Prior to that, she completed her PhD in clinical psychology at the University of Cincinnati, followed by an NIAAA-funded postdoctoral fellowship in alcohol epidemiology, which brought her to Pittsburgh. She currently oversees all of IRETA's applied research and evaluation projects. Okay, Dr. Luongo, if you're ready, I'll hand things over to you.
Thank you, Jess. Good afternoon, everyone, and welcome to our webinar on implementing recovery-oriented clinical services and opioid treatment programs. This is an update on a pilot. This is the second webinar in a series that'll report on this clinical quality improvement program. I'd like to welcome back any of you that joined us in our initial webinar in May, and welcome to people who are joining us for the first time. We're going to catch up about what this project is and present some data. And a special welcome to my friends Rory and Sue. Rory is a little under the weather and wanted to join us for this webinar, so Sue is helping her today do that. Thank you very much. IRETA has been around for 20 years. This is our 20th this is our 20th anniversary, and what we do is help people effectively respond to substance use and related problems. So we're in the business of helping helpers do what they do better, and we're not alone in that. Many thanks to the programs that are participating in our clinical quality improvement, and much credit to Southwest Behavioral Health Management for the foresight and leadership to help make this program, this multi-year program, possible. And at IRETA, this is led by Dave Reason, who heads our clinical quality improvement group. So let's start, talk a little bit about what's going on today with OTPs. The national completion rates hover between 11 and 14%. Retention is actually dropping. Clients enter OTPs more for a respite and a timeout, and then they move on. It seems like OTPs have evolved as a harm reduction, not a recovery-oriented service. And unfortunately, it didn't start this way. The needs of the medication, not the client, seem to organize the program. So this is a bit of a review of why this clinical quality improvement program would be important. And a recovery orientation means something really specific. It shifts the focus from program-based care to client-based care. So instead of everybody getting the same thing, you fit a treatment in sets of treatment interventions to where the client is, and you adjust it based on the effectiveness of the interventions. So medications are important. They are useful, very useful tools in keeping people alive and stabilizing them, but they shouldn't be the sole focus of opioid treatment programs treatment. And what you really need is a comprehensive clinical needs assessment. You need standardized placement criteria, and you need to match the client to the most appropriate level of care. That's what a recovery orientation looks like. And back to this for a second is the fact that right now in OTP, methadone is considered not just a medication, but a level of care. So what we're doing right now is we're implementing recovery-oriented outpatient services in existing OTPs. 6 have been selected. We've completed a pilot site, and we're going to be talking about some of the results from that. And there are 2 that are active right now. We have another 3 to go. There's 2 years that we spend on site at each OTP. So this is not a training program. This is a cultural change. It's a consultation. And here are some of the things that we end up doing in those 2 years to start with. We review and analyze outcome and performance data for the past 2 years, the 2 years prior to us entering into the program. We take a look at all the policies and procedures. We attend staff meetings. We're guests in the house of this program. And they're going to see a lot of us, but they need to get to know us. We review clinical record keeping. And then one of the unique aspects of what we do is we observe counselors practice. This is all done with the agreement of everyone. We spend time talking about what this project is. We talk about it with leadership, and leadership talks about it, and we do with staff. We look at individual sessions. We look at conducting how group sessions are conducted. One of the things that we've learned over the years is that training alone isn't sufficient. It's necessary, but not sufficient. This consultation model, this clinical quality improvement model that we've been testing, works on site in the place where people work. We look at the ways which professionals learned their clinical skills, and we try and replicate that on site. So here are some of the things that we do on site. We talked about what kind of a clinical orientation would be useful for establishing therapy groups on an ongoing basis and clinical services. And for the initial pilot and subsequent programs, the selection of CBT seemed to be most appropriate. Most counselors in any of their training have become familiar with CBT. The concepts are easy to understand, it's easy to operationalize, and it translates very well into a problem-solving approach and very well into individual and group counseling. We've done work on introducing group therapy concepts. For the most part, what we were going to be introducing here, weekly therapy groups, were not the norm in OTPs. And I'll explain a little bit more about why. So we did advanced training and application in the use of CBT. But what we did was do all this on site at the program. We didn't pull anybody out of their surroundings to do it. We also introduced case consultation as quality assurance, not clinical supervision, which turns out to, in practice, be more of an administrative supervision. We wanted to talk about cases, how it was going, individuals' treatment plans, modification in the treatment plans, how interventions would match the problem issues that were identified in treatment plans. And we wanted to introduce recovery-oriented methadone maintenance. Some years back, a monogram was published jointly by Great Lakes ATTC and IRETA, written by Bill White and Lisa Majors Torres, about recovery-oriented methadone maintenance. And we use that as the conceptual and theoretical basis. But what we do is translate that into practice. So once we've done those activities that were on the implementation side, the beginning side, the next thing we did was survey clients on their treatment satisfaction, their perceived needs, and their openness to changes in their treatment. For the most part, people were getting 2.5 hours of clinical time a month. And here we were asking, would you be interested in more? And we'll be talking more about some of these results. We then implemented the ongoing CBT groups. Clients were assigned to a group that meets weekly, and they are assigned to a primary counselor. The group meets at the same time with the same therapist. And originally, we worked for a 3-month CBT-oriented group. It became quickly clear in the pilot program that more was needed. It expanded to 24 weeks, 6 months, and it has kept going since then. All new clients in this pilot were assessed for level of care. They were offered a level 1 clinical service. As you know, in ASAM, a level 1 service is up to 9 hours a week. The program that was offered, and it was voluntary. Not every client that was assessed to that level of care was required to do it, but they were all assessed and offered, if appropriate, assignment to a counselor for a weekly individual as well as to a therapy group. The second thing that happened was all clients who were relapsing and not doing well in the usual and customary program were reassessed and offered the group therapy. So in the pilot program, it wasn't a requirement for new clients entering the program to go to the weekly group. They were offered it if they were assessed as needing level 1 services. But relapsing clients who normally would have been sent out of the program were offered the opportunity to participate in what became known in the pilot site as enhanced counseling. And we continued the case consultation and process improvement by how we conducted ourselves with counselors. All the groups that we did, we didn't facilitate, but we were there observing. And then we debriefed afterwards with the counselor. And there was also a patient satisfaction survey, and we'll show you more about that. But when we looked at what was happening at the pilot site before we began, the outcomes at the start were at the low end of the national averages, about 11%. There really wasn't any particular orientation. So it was somewhat eclectic, but really what happened was mostly case management in an individual session, and then open thematic groups that you would sign up for. And some groups, as you may know if you've been involved in OTPs, are required every year. And in Pennsylvania, you're required to have 2.5 hours of clinical service. The groups that were offered were really thematic groups that met for about an hour and a half, and group membership would rotate. There wasn't really a recovery orientation. And the groups, as I said, were didactic, open, thematic, and disconnected to any kind of a theory of change. The clinical staff really displayed that they were competent, but they were frustrated because the program design limited their scope of practice. So we had some very specific kinds of questions that we wanted to answer when we were going into this pilot. We knew there was a limited amount of clinical time that was being spent, 2.5 hours a month in Pennsylvania. Most of the time was case management or these didactic open-ended group. There was not any resistance or reluctance. There was curiosity about whether this type of clinical enhancement could actually be done. Or was methadone always going to be its own separate level of care instead of just a medication? So here were some of the questions that we had in doing this pilot site. Can weekly therapy groups be established in an OTP? There was a considerable amount of fear and skepticism that people would want to do it. And there was also a fear that if they were required to do more, they would simply leave the program and go somewhere else. Are the patients willing to attend the groups? Do patients see the groups as important to their treatment? As you might recall from an earlier slide, one of the things that we did right away was a survey of clients who were already engaged in treatment in the program to see what they thought they needed and whether they would consider doing a weekly group. Would they consider spending more time at the clinic? So these were 3 questions that we had, but there were more. Are staff able and willing to lead the groups? Because we were working with existing programs, it was really important that staff become engaged. And there were ongoing questions whether staff were going to be able to do this CBT-focused recovery orientation. Did they have enough training and education? Do the staff see the groups as an important part of treatment? Or is it just something more that we're supposed to do that really shouldn't have to be done by us because we already meet the standards that have been set by our licensing site and by our accreditation body? And most importantly, do the groups contribute to improve patient and program performance? So these were the 6 questions. This is kind of the proof of concept to doing OTPs in a clinical quality improvement model. Could you push in against what are kind of minimal standards? Would people want to do this? Could people do this? Does this make sense? So these are the 6 questions. If you recall from an earlier slide, one of the things that we found right away from watching staff and being part of individual sessions and group sessions that were already there was that staff were really competent interviewers and that they were really constrained by the way the program was designed as to what they could do. So we've got some data, and that data is going to be presented by Dr. Dawn Lindsay, and I am turning this over to you. Dawn?
All right, thanks. All right. All right, thank you, Dr. Luongo. I'm happy to discuss the data we collected during this pilot study. Other than administrative data, such as attendance and that sort of thing, the primary measure I'll be discussing today is the weekly survey that was referred to that all the clients participating in the groups completed. That survey included questions about client satisfaction, as well as how clients said they coped with cravings and whether they felt that their medication dose was effective in controlling their cravings. This survey really got to the heart of what we were trying to demonstrate, which was acceptability and feasibility of doing this type of treatment in OTPs. The data today will be organized around those 6 questions that Dr. Luongo just summarized. The first question, can weekly therapy groups be established in an OTP, can be answered with a resounding yes. As you can see in this chart of the number of clients who attended groups per month, about a dozen or so were attending within the first few months, and that number kept growing until about 6 months in there was actually enough demand that an additional group was added at that time. And then the numbers kind of stabilized because we wanted to keep the groups, to be a reasonable number. Other than a bit of a drop-off heading into the summer of 2018, participation was really quite consistent over time. And in the anecdotal evidence of all of the comments that we received in the weekly surveys, the clients really looked forward to attending this group and attending those weekly sessions with their therapist. So are patients willing to attend the groups? Again, what we found was that patients were quite open to trying out this new mode of treatment that many of them had not encountered before for the most part. As an example, this scatter plot that you can see shows that clients who attended more frequently also attended more sessions in total. So to break it down just a bit more, clients who attended a total of 10 sessions attended twice per month, whereas clients who attended a total of 20 sessions averaged closer to 3 times per month. While we're not sure exactly why this is, these two indicators are certainly linked and seems to really be echoed in a quote from one of the clients on their weekly survey that caught my eye, which was this individual said, "The longer you participate, the more you get out of the group." So the final patient question that we had was, do patients see the groups as important to their treatment? We had several indicators of this. The best indicators were those satisfaction questions on the weekly survey, where upwards of 99% of clients agreed that the group was supportive and helpful in general, and helpful to their recovery specifically. A large majority also agreed that they would recommend the group to a friend, which, in my opinion, I find to be one of the most powerful and effective satisfaction questions to ask in just about any context. All right. So I'm going to switch gears just a bit and discuss the next couple of questions that refer to the staff. So turning to the staff of the programs, are staff able and willing to lead the groups? Another item from the weekly survey asked whether the counselor was familiar with the topic of the group, which again, clients overwhelmingly agreed. But beyond this one specific question, the comments provided on the weekly survey again provided even richer data that really spoke to this question. Dozens of mentions of how wonderful and effective the group leaders were supported the idea that these clients had really established a personal connection or rapport with their therapist beyond what might be expected in a more didactic or educational group. So a little bit more difficult to measure, but certainly noticeable in the comments were, again, the clients really felt connected to the group and felt that it had some place to go and someone would notice if they weren't there. So do staff see the groups as an important part of treatment? To answer this question, I turned to my notes from the stakeholder meeting that we held at the end of the pilot period of this project. Key staff at the clinic were clearly committed to continuing groups after our official role in the project was over. They had the staffing, they had the space, they had the reimbursement structure to ensure that this would continue. In my opinion, a big part of the buy-in came from seeing the effects of these groups on the clients. Stories were shared of clients who were discharged to residential treatment or even ended up incarcerated and later re-engaged at the clinic and resumed attending the therapy group, which apparently was not a typical occurrence previously. One of the group facilitators shared that she literally could not imagine going back to the way things were previously. There was definite engagement and definite buy-in from the staff. To answer the final question, I'm going to share a couple more slides. I want to share a chart of client status at the end of the project. The fact that the very large majority of clients were still considered active at the end. could certainly be considered a positive outcome. In fact, only 4% of the overall 50-some clients that we followed throughout the pilot project had voluntarily just left the group prior to being considered complete, which is, as you probably all know, a pretty good outcome. It's a pretty low number of attrition. The last slide I'd like to discuss is a comparison of craving over time. And I'll get in, this is a little complicated of a slide, so I'll get into this a little bit. As I mentioned, one of the questions on the weekly survey was whether clients agreed that their current medication dose was controlling their cravings. So we compared two groups of patients, and you can see on the two charts here, those who never disagreed that their current dose was controlling their cravings. In other words, they were doing fine. They reported that they were doing fine with their dose. The other group was clients who at some point did state that they felt that their dose was not controlling their cravings. So those are the two groups that we looked at. For clients who were doing fine, who said, yes, my dose is fine, it's managing my cravings, there was no real movement in this item over time. Now, as you can see on the left side of the slide, on the other hand, for clients who did have perceived issues with their dose managing their cravings, you can see an increase over time in this item. At around the 10th to 12th session or so, rates of agreement with the item, is my dose managing my cravings, were actually similar between the two groups. So our interpretation here is that this item, my dose is controlling my cravings, might really be a proxy for how well the client is coping with cravings in general, and that participating in the group may have played a role there, at least for clients who were struggling more with cravings at the beginning of their participation in the group. And so the last sort of slide that we want to take a little bit of time to discuss is turning to next steps. So as Dr. Luongo indicated, this is a work in progress. This was the pilot site, and we have several more sites in progress and to be started up. And I think what I want to underscore is that we're moving toward, we learned a lot at the pilot project, and what we're moving toward is a more sort of rigorous, structured design for collecting data and for analyzing that data. As Dr. Luongo mentioned, this is a concept. This is proof of concept. This is looking at the very basic level of acceptability of this type of treatment being introduced in an OTP, and feasibility. Can it be done? What we want to move toward in future sites and future projects is this sort of global data analysis plan where we have a number of baseline measures, such as retention rates. In prior years, we would get clinic data and that sort of thing. We'd measure drug use over time, employment rates, all of those key indicators that we all know are so important to recovery from addiction. We'd have clinical matching. We would have the ASAM criteria match, level 1, level 2. Our expected outcomes, which we just touched on very briefly today, would be things like improved retention rate, increased abstinence rate, improved employment rate, decreased arrest rates, and the indicators to the right of those expected outcomes you can see would be things like days in treatment, all things that are easily measurable by us and, more importantly, easily monitored by the clinic staff, because one of the factors in these types of projects is we want to empower these clinics to look at their own data over time and to use it to improve what they do. So with that, I think I can turn it back over to Dr. Luongo. If that's all right with you, I'll just go to our thank you slide and we will start taking some questions.
Yeah, so
thanks everyone.
Dr. Lindsay. One of the important things here is an acknowledgement that, as Dr. Lindsay said, how this was a proof of concept. Our partner program here did a wonderful job in accepting us for a couple of years to work side by side with them. And at the beginning, we were at the clinic, the program, 3 days a week, and then 2 days a week. And looking at, and fearlessly looking at how they were doing. They were in absolute agreement that they would like to do things differently. And I have to say that this was, the name of the program was Foundations Medical. They're a part of the pyramid healthcare system, and they did a wonderful job. The next steps for us, now that this is in fact, it can be done, is, as Dr. Lindsay says, move us into a more systematic analysis. We've gotten much better at how we would approach in a program and how we would more efficiently start and train. We are scaling our internal capacity upward. We've hired another clinical staff person who is part of the clinical quality improvement, and we'll be recruiting for additional people. There's an interest in how to have methadone be a medication, not a level of care. And in states that are using the ASAM criteria now and doing multi-dimensional assessments, you're looking at being able to provide clinical services, recovery-oriented clinical services, outside of simply 2 or 2.5 hours a month. You're moving from program-focused care to client-focused care. So we have 2 projects, 2 programs currently underway, one that began in March 2018, another that began in September 2018, and we'll be beginning another program probably in February, maybe late February of 2019. So we keep track of what we're doing here. We think that this is an exciting project and that there is an ongoing interest from the treatment community in learning how to incorporate level 1 and level 2 outpatient services. And with that, I'll go back to Jess and ask, do we have any questions?
Sure, yes, we do. The first one that came in is asking about how large were the clinics that you worked with, and what was their overall patient census? What percentage of those clients participated in the pilot, and were they considered volunteers? And are there any thoughts on whether you can implement these procedures for all clients?
That is a lot of questions. They were all volunteer. The program was reluctant to mandate that new clients coming in, even if they were assessed to level 1 clinical services, had to do that. They were offered the opportunity to do it. And they also offered the opportunity for people who were relapsing in lieu of leaving the program for another level of care to enter this enhanced counseling. The pilot program was relatively small as these programs go, which I think had, in fact, a census. I think they had about 300 patients, which is relatively small, and it's in a rural area. And I'm sorry, what was one of the other questions that was part of that, Jess?
Oh, yeah, sure. Any thoughts on, okay, yeah, so it was, what was the overall patient census, the percentage of clients who participated, and thoughts on whether you can implement the procedures for all clients?
Yeah, I think we had about 45, a little over 45 patients who participated. And in a negotiation that we have right now with a larger setting, we're going to introduce the concept that if someone is assessed to a level 1 clinical service, that's really what they should get. So we're in a position, because of the pilot, to say, this should really be, at least for 3 months, what everybody who comes in and is assessed as needing level 1 clinical services, because there would be a 90-day treatment review, and you can see if it in fact is the level of care that they need. The other thing that we're interested in doing, we think will add great value, is if a program is of a sufficient size, and we're looking at programs that are in excess of 600 patients, that you would have on site a level 1 and level 2 intensive outpatient service, so that if clients need more intensive services than what is provided at a level 1, they could come multiple times a week for services. As you may know, level 2 intensive outpatient services are up to 16 hours a week, from 9 to 16 hours a week for adults. So we're offering the opportunity that if a program would like to do it, to be able to offer a clinical level of service that fits where the client is at. And if they're not doing well, intensify service without having them leave the program. So yes, we think that's really doable. Thank you.
Okay, the next one that came in is, how is the program reimbursed? So they gave some examples. Was it Medicaid, private insurance, client pay? And how was the way that the program reimbursed related to outcomes, do you think?
Okay, let's talk about reimbursement. When methadone is thought of as a level of care, there is, in the original presentation that we did in May, we talked about the administrative elegance of reimbursing by a weekly set fee. But the problem with that was that the services never went beyond the minimum that were required. It was program-focused care. In this particular pilot program, again, sponsored, the foresight and leadership from Southwest Behavioral Health can't be overstated. They separated out payment for medication services. There was a weekly fee computed for that. And then the clinical services, the individual services and the group services, were reimbursed as they would be in any outpatient level 1 service. These were limited to Medicaid patients, but the patients in the programs that we're working with were more than primarily Medicaid patients. So you went from a weekly set fee to a fee-for-service reimbursement, and that's how it was done, and that's how it's going to continue to be done for the pilot site.
All right, thank you. The next one we had come in is, has there been any discussion or plan for any of your findings to be published for reference, or are you looking at creating a toolkit to share with other agencies?
Well, there are a couple of things. Our data analysis plan means that we're moving towards being able to have research that helps us know what's working best and improving patient outcomes. So we are moving towards being able to have a research design that would be able to be published ultimately in a peer-reviewed journal. So far, everything that we've seen leads us to think that that is going to happen. And we're negotiating right now for a project that would have a sufficient resources devoted to it that would allow that. We have created for our internal use right now an implementation manual. We did that because we needed to track how we did this step by step, track the modifications that we made, and frankly, we're scaling this up. So we have new clinical consultants who are going to be part of IRETA's team, who will be full-time employees here that we need to train. As a matter of fact, today we had an internal discussion about making another book, which would be left with a program about how to do it, how it's been done, how to sustain it, what are the processes you need to have. So, ultimately, when we're comfortable and when we've got something that's replicable and able to be followed, we intend to publish those results and make them widely available. Thank you, Jess.
Okay. Do we have time for a couple more?
I think we're good.
Okay. Were there any drug screen comparisons done? And if so, did group participants have better outcomes versus non-participants?
We really wanted to do that sort of a thing, and we have some data, but it wasn't systematically collected over time. So that is part of what we're doing, being able to look at. We're also constrained by the data system that a program might have. The pilot site went from a paper record to an electronic health record kind of in the middle of what we were doing. So we weren't really in a position to be able to, on the pilot site, or really want to track that. We were really trying to answer those 6 questions that we had. This was really a proof of concept. It's really something we're interested in.
Okay. What time of day were groups offered? Were they during dosing hours or after?
They were early in the morning, right after dosing. So you would have groups that would be running at 7:30 in the morning. Our staff were on site in most cases by about 5:30 or 6 in the morning to be able to work with the counselors. So people were there, didn't have to come back.
Was it difficult to change the culture from individual to group treatment amongst both patients and staff? Where groups were required, and if so, how do you get the initial buy-in?
Well, this was voluntary, and there was kind of a marketing job that counselors did. And then what happened, as you saw with the satisfaction survey, and we took a survey of clients after every group, and that was entered into a database, and so gave us an opportunity and the program an opportunity to take a look at it. Turns out clients who were in the group who really liked it were the best source of being able to recruit new members. Staff were selected. They self-selected, and they were selected by the leadership, those people that expressed an interest in it, and they seemed to have no problem. Our staff was extraordinarily available and accessible, and formed a good partnership with the staff of Foundations. So it wasn't a requirement; it was voluntary, as I said. So in some ways, the people who got into this group were people, for the most part, who were not just starting in the program, but were the people who were about to fail out. So in our mind, it probably made the results of the pilot even more impressive. Jess?
All right. The next one is OTPs are currently highly regulated, which often includes dictating the frequency of certain services. How do you recommend programs follow medical necessity while also maintaining regulatory compliance, especially as we move toward more payor coverage?
The issue now is the discussion about not how many services are provided. Technically, an accreditation and what SAMHSA requires was, outside of Pennsylvania, up to 2 hours of clinical time a month in certain groups. When that was instituted, there were people who said, you've just established the ceiling, and SAMHSA was saying, oh no, we established the floor. Well, as long as you are hamstrung by a weekly fee, you're going to make your budget by doing as few services as possible. So in order for this to be feasible, medication is a separate piece, and there are, of course, 3 medications that are effective for use with opioid use disorders, including methadone, buprenorphine, naltrexone, you're looking at billing services as any other clinical service in substance use disorder treatment. So if I had a level 1 outpatient service, that's how I should bill on a fee-for-service basis. So what this pilot is also demonstrating is there's an economic model, and we haven't really spoken about that here. We focused on the clinical side. The economic model here is that you're reimbursed for the services that you provide, and the cost of the medical service are paid for on a weekly basis. This really is the future of how services in a specialty addiction service are going to be provided, because you're going to have to look at client-focused care, because payers are going to be looking at the value purchase, meaning how are patients doing. So that is the shift that's taking place nationwide. And this pilot takes advantage, and this clinical quality improvement takes advantage of it by separating essentially medication out from the clinical service. Yes, it's done at that program, but it's showing that OTPs can be far more clinically oriented and recovery oriented than providing a set 2 hours of clinical service a month. Thank you. Yes.
All right. Did you follow a particular CBT skill building recovery oriented set of groups or some other format?
No, it really was a CBT format. What we did was not look at a manualized approach, like taking something off the shelf. We looked at the skill set that the counselors had, and we looked at how you would have a recovery orientation. And we actually wrote, and much credit to Dave Reason for doing this, we wrote 24 sessions that were not to be rotely followed, but provided a structure and an outline within the context of cognitive behavioral therapy. Even groups were about an hour and a half, and we had probably over 2 hours worth of material, including client handouts, homework assignments. And it was a way for us to teach the counselors, how do you stay within a CBT format? We also help teach how do you write treatment plans to CBT, and how you chart progress notes to the treatment plan. How do you update treatment plans? So as a teaching tool, we had a 24 structured sessions that we wrote, Dave wrote.
Okay, and the last one we have here is, other than weekly surveys, was there any other involvement from participants during the data collection or data analysis process?
Well, there were a lot of feedback, verbal feedback, and I think the changes that were made, but there was no formal focus group that was held. Mostly our feedback was the survey, but also because one of us was there at every group, there was a way to process with the counselor what was happening with participants. So participants here, in our mind, probably had more say over things than what they normally would have. But to answer specifically, it was the weekly satisfaction survey they were given after every group. Jess, anything else?
All right. I think that, we did have one more come in. What are your thoughts or experience, if any, with using contingency management groups?
Well, I professionally have experience using contingency management and installing that. That is a possibility. So far, at the pilot site, when we were working before doing our due diligence, and in the first 3 months collecting data, we had discussions with the clinical leadership and the program leadership about what kind of an orientation did they want. And contingency management was one of them. And they really preferred to go with CBT. And frankly, that gives you quite a bit of flexibility and gives the counselors the opportunity to be consistent in individual work as well as in group work. Contingency management is an option that has to be carried through everywhere in a program, and is probably one of the better interventions when perhaps your staff is not as well trained to do CBT. But so far, it hasn't been a choice that anybody has made.
All right, those are all the questions that have come in. If anybody has any more questions that they come up with after we're done here today, you can feel free to email them to info@ireta.org, and we'll be happy to get some answers back to you. At this time, I just would like to thank Dr. Luongo and Dr. Lindsay again for such a great webinar. I want to go over our evaluation and CEU instructions. Everybody's going to receive an email from us following the webinar that will include a link to the evaluation. Our evaluators are pleased to collect feedback from all event participants. Completion of the evaluation is critical to continue to provide quality education and materials. Your participation is appreciated, and the evaluation should take no more than 2 minutes of your time. To request a certificate of attendance or NADAC and PCB CEUs, you will need to log into your My IRETA profile. Once you're logged in, you'll go to today's webinar and then select the type of certificate you would like to download. Please note that certificates may take up to 48 hours to appear in your profile, so again, we ask for your patience. The second email will be sent around to all registrants early next week and will include a link to the recording of today's webinar as well as a PDF version of today's slides. Again, we want to thank everybody for your participation, and if you have any questions, please email us at info@ireta.org. Thanks so much, everyone.